1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
So imagine you have a pregnant client, right? She's sitting there in the triage room.
Okay, setting the scene. I like it.
Yeah, and her partner is right there beside her, holding her hand, gently rubbing her shoulder, and answering every single question you ask before she even gets a chance to open her mouth.
Right. Very common scenario.
Exactly. And your first instinct, just as a human being, might be to look at them and think, wow, what an incredibly supportive partner. Like, she's lucky.
Which is such a natural reaction, but clinically speaking,
Yeah.
it is one of those dangerous blind spots in nursing.
Wow.
Yeah, you look at that and you see support. But if you don't know the exact protocol for assessing interpersonal violence, you might actually be looking at isolation and control.
And just totally miss it.
Totally miss it.
Yeah.
And if you handle that interaction the wrong way, the consequences are, they're catastrophic.
Yeah.
That simple assumption could put her life in immediate physical danger.
Which is exactly why we are here. So welcome to the deep dive. Today, we are acting as your elite OB nursing educators, your clinical mentors, and basically your exam coaches.
Absolutely. We are so glad you're here with us.
We're looking at the holistic side of maternal and newborn care. And our mission for you today is very, very specific.
That's right. We are aggressively applying the Pareto principle to your study material today.
Like, no boring textbooks here.
Nope, definitely not. We are sifting through all of the noise to pull out the 20% of high-yield concepts, things like social determinants of health, cultural competence, and substance use.
Because those are the concepts that give you 80% of your exam value, right?
Spot on. We want you to pass your exams, obviously, but more importantly, we want you to think like a safe future nurse.
Because you can, memorize every single lab value in the book, but if you don't understand the why behind a patient's stressors,
you're completely missing the full picture. The environmental and social factors we are discussing today, they don't just make a pregnancy stressful. They physically alter fetal outcomes and maternal survival.
literally changing the physiology.
Exactly. Before you can even think about treating a clinical symptom like high blood pressure or premature labor, you have to understand the environment that patient is returning to, because the environment dictates the risk.
Okay, let's unpack this. If you are looking for the ultimate high-yield core concept for your exams, you have to look at the social determinants of health.
Yeah.
Or SDOH.
Yes, massive topic.
What you're talking about, economic stability, education, the neighborhood, the socio-political climate, which includes racism and systemic poverty.
Right.
But I want to push beyond just listing those things out, because how does living in, say, a food desert or experiencing systemic racism actually cause a medical emergency, like preeclampsia or preterm labor?
That is the critical question. To understand the actual mechanism, you have to look at the physiology of chronic stress. It's a concept often referred to as allostatic load, or weathering.
Weathering. Okay.
Yeah, think of the human body like an engine. When you are constantly stressed, worrying about paying rent, experiencing racial discrimination, living in an unsafe neighborhood.
Your body's fight or flight response is just like constantly activated.
Exactly. Your engine is perpetually running at the red line.
So you have cortisol and adrenaline just constantly pumping through your system.
Yes. And over time, that chronic flood of stress hormones, it causes premature vascular aging. It literally damages the blood vessels.
Wow.
It raises baseline blood pressure. So when you add the immense physiological strain of pregnancy on top of an already damaged vascular system, that is when you see catastrophic failures.
Like severe preeclampsia or placental abruption.
Exactly. The social environment directly causes the physical breakdown.
Which perfectly explains a priority exam fact that every single nursing student needs to have permanently etched into their brain.
Which one is that?
The glaring, frankly unacceptable disparity in Black American maternal health.
Yes. This is a critical safety and equity issue. On exams, and in real life. In the United States, pregnant Black clients are 3 to 4 times more likely to die from pregnancy complications compared to non-Hispanic white clients.
3 to 4 times, that's just staggering.
And they face double the risk of experiencing severe maternal morbidity. That disparity is a direct physical reflection of those social determinants of health.
So as a nursing student, when you hear those statistics, it can feel completely overwhelming. I mean, you can't just fix systemic poverty or reverse decades of weathering in a single 12-hour shift.
Right. You're not a superhero. You're a nurse.
Exactly. So how does a nurse practically address this cracked foundation, especially, when keeping their own scope of practice in mind?
Well, that brings us right to a major top exam trap.
Oh, instructors love testing this.
They absolutely love it. They love testing the boundaries of delegation and scope of practice, specifically the difference between the registered nurse, the RN, and the practical nurse, the PN.
Okay, so what's the trap?
The trap is assuming that because a client's social needs are complex, you can just delegate the entire care plan to the team.
But the PN scope of practice varies heavily by state, doesn't it? I mean, an RN can't just hand off a complex preeclampsia patient to a PN and say, figure out their care plan.
Never.
Yeah.
Never, ever. And the reason exams test you so hard on this isn't just, bureaucratic red tape. It's about legal liability and patient safety.
Because if they do it wrong,
You risk your license. In some states, a PN might contribute directly to the plan of care, but in others, they're strictly limited to assisting the RN.
so the RN is always at the helm?
Almost universally, yes. The PN must practice under the supervision of an RN, and the RN is ultimately responsible for the initial assessment and the primary care plan. Your priority action here is to always know your specific state guidelines.
Okay, so we understand the physical toll of these social determinants, and we know our legal boundaries in creating a care plan. The next logical hurdle is figuring out how to actually uncover these hidden dangers. Because a patient isn't going to just walk into triage and announce, hey, my allostatic load is extremely high because my partner is abusive.
No, they are definitely not going to do that. And that is why therapeutic communication is such a high-yield core concept.
It's an actual skill.
It really is. You cannot uncover hidden dangers without highly specific techniques. You have to earn the right to hear their story. And one of the most effective tools you have for this is the concept of offering self.
Offering self. I mean, I love the way that sounds, but what does it actually look like in a clinical setting? Is it just like pulling up a chair and being polite?
It goes a lot deeper than politeness. Offering self means showing your presence, your interest, and your unwavering attention without any judgment or expectation of an immediate answer.
You're just holding space for them.
Exactly. You are essentially telling the client, I'm here, I have time for you, and you are safe. And then you combine that with open-ended questions.
And this isn't just about building rapport, right? Like, this is a highly calculated clinical tool to assess safety, specifically regarding interpersonal violence.
Absolutely. Interpersonal violence affects anywhere from 2 to 35% of pregnancies.
35%, that's huge.
And that staggering number is likely an underestimation because victims are terrified to report it. During pregnancy, the most common perpetrators of violence are people the client has or had an intimate relationship with.
And the clinical fallout from that is severe.
Very. It includes delayed prenatal care, postpartum depression, low birth weight, and preterm birth.
Which brings us right back to the scenario we opened with. The supportive-looking partner holding the client's hand. If I'm an examiner, this is exactly where I am setting a top exam trap.
Oh, absolutely. The prompt will ask what your priority action is to assess for interpersonal violence in that exact moment.
And the trap is thinking you can just, subtly ask the client while the partner is sitting right there.
Yes. You never, ever screen for partner violence with the partner in the room. Ever. The perpetrator often uses isolation and control to keep the victim quiet.
So if you ask right in front of them,
The client will almost certainly lie to protect themselves. And worse, the perpetrator may punish them later just for being asked.
so what is the actual priority nursing action then?
You must ensure complete privacy. You have to invent a clinical reason to separate them if necessary, like taking the client to the bathroom for a urine sample, or stating that hospital policy requires a brief individual assessment.
Clever.
You must ask those open-ended questions when the client is entirely alone. That is the only way to protect them from immediate physical danger.
And what if, during that private screening, you start to suspect human trafficking? Because we know risk factors include that same limited access to care and housing we talked about earlier.
Right.
What is the move there? Do we investigate further, ask more probing questions?
No. That is an absolute, unquestionable, report immediately situation. If human trafficking is suspected, the nurse must report the concern to their direct supervisor immediately.
So you do not play detective.
Do not play detective. The brief time they present for care might be their one and only window for intervention, so you escalate it through the proper channels instantly.
Okay, to help you lock this screening process down, let's give you a memory anchor. When you have the client alone, you want to use the HIT's screening tool. Think of the acronym HITS: hurt, insult, threaten, scream.
It's a great tool.
Yeah, you're basically asking how often their partner physically hurts them, insults them, threatens them with harm, or screams at them. It just gives you a structured way to ask extremely difficult questions.
And here is where we connect this to the bigger picture. When nurses successfully create that safe, private environment using tools like HACs, another major risk factor very often comes to light.
Which is?
Polysubstance use.
Oh, right. Using more than one substance at a time. This is a topic that can get really murky for students because there are so many different substances and side effects.
It can be a lot to memorize.
Let's start with the basics: expected versus concerning findings. When it comes to alcohol during pregnancy, what is the expected safe limit?
There is no expected or safe level. None. Even a single glass of wine carries risk.
So any amount is concerning.
Highly concerning.
Yeah.
Because it leads directly to fetal alcohol spectrum disorder, causing irreversible cognitive and behavioral challenges. It also drastically increases the risk of sudden unexplained infant death, or SUI.
And what about tobacco?
Smoking is a massive priority because of the physical damage it inflicts. It literally damages the structure of the umbilical cord.
Wow, the cord itself.
Yeah. It restricts blood flow, causing intrauterine growth restriction, low birth weight, and it significantly increases the risk of placental abruption.
Okay, here is where it gets really interesting and where students consistently lose points on exams. Mixing up the specific dangers of illicit drugs.
This is a huge trap.
Let's do a side-by-side comparison of two major exam traps. Cocaine versus opioids. If I have a patient who is actively using a stimulant like cocaine, my mind immediately goes to the cardiovascular system. I'm thinking their heart rate is through the roof, maybe respiratory issues.
You are right to think about the cardiovascular system, but you need to take it one step further to the actual obstetric emergency. Cocaine is a massive vasoconstrictor. It aggressively clamps down on the blood vessels.
Okay, so how does that affect the pregnancy specifically?
Think of the placenta as a giant blood-filled sponge that is firmly attached to the uterine wall.
Okay, got the sponge visual.
When cocaine causes the maternal blood pressure to violently skyrocket, that sudden high-pressure system literally shears the sponge right off the wall.
Oh, wow.
That is your placental abruption. It also causes premature rupture of membranes. So if you see cocaine or methamphetamines on an exam, your brain needs to immediately scream maternal hemorrhage and fetal loss.
The shearing the sponge metaphor makes total sense. Vasoconstriction leads to pressure, pressure leads to hemorrhage. Got it. Now what about opioids? Opioids are central nervous system depressants, so the risk profile completely changes, right?
Exactly. The primary threat shifts from a maternal hemorrhage to newborn withdrawal. If you see opioids, with a prescription or illicit, your brain needs to instantly pivot to neonatal abstinence syndrome, or NAS.
So what are the priority nursing actions for a newborn with NAS? What does that assessment actually look like?
To understand the assessment, you really have to understand the mechanism. Think of the infant's nervous system like a coiled spring.
Okay, spring.
While in utero, the opioids acted like a heavyweight pressing that spring down, totally suppressing the nervous system. When the baby is born and the opioids are suddenly cut off.
And that weight is removed.
Precisely. And the spring violently snaps upward. The nervous system becomes wildly overstimulated. You will see a highly irritable baby.
What are the hallmark signs?
The hallmark signs are a high-pitched, inconsolable cry, hypertonia, which means their muscles are very rigid and stiff, tremors, seizures, vomiting, and loose stools.
Wait, if the infant is in severe withdrawal, having tremors and a high-pitched cry, my instinct would be to give them medication to ease the withdrawal. Do we immediately jump to pharmacological treatments like a slow morphine taper?
We do not, and that is a massive exam point.
Really? Because that sounds like the logical medical step.
For decades, we did exactly that. But we found that giving more drugs just prolonged their hospital stay and didn't solve the core issue. The priority, first-line intervention today is the Eat, Sleep, Console model, or ESC.
Eat, sleep, console. But how does just holding a baby stop a literal chemical withdrawal?
Because it actively rewires their overstimulated nervous system. The NICU is bright, it's loud, it's full of sensory overload. The ESC model teaches parents to meet the infant's basic needs in a low-stimulation environment.
So taking away the chaos.
Exactly. You keep the room dark and quiet, you swaddle them, you feed them on demand, you promote skin-to-skin bonding. This natural soothing calms the coiled spring faster and safer than a slow drug taper.
That's incredible.
Pharmacological intervention is strictly reserved as a second-line treatment if ESC fails.
That is fascinating, and it brings up a really vital point about patient education, especially if a mother is prescribed methadone or buprenorphine to manage her own substance use disorder.
Absolutely. The nurse must educate the mother that even though she is taking a prescribed, closely monitored medication, the infant will likely still experience NAS.
Which has to be incredibly guilt-inducing for the mother to hear.
It is heartbreaking, which is why you must reassure her that the clinical consensus is absolutely clear. The benefit of remaining on a monitored prescription opioid far outweighs the chaotic, severe, and often fatal risks of returning to illicit drug use.
Right. But think about the level of trust required to have that kind of conversation. Managing substance withdrawal, utilizing the ESC model, screening for intimate partner violence. I mean, none of this works if the patient doesn't trust you.
Trust is everything.
If the client feels judged by their culture, their background, or their identity, they are going to shut down. They won't comply with care, and they won't come back for follow-ups. And that leads right back to those catastrophic outcomes we are trying to prevent.
Which is exactly why cultural competence isn't just a buzzword. It is a literal clinical lifeline.
Yeah.
And you need to know the difference between cultural awareness and cultural competence for your exams.
They aren't the same thing.
Not at all. Cultural awareness is simply understanding your own biases and recognizing that other cultures exist. It is completely passive.
So cultural competence is the active step.
Correct. Cultural competence is delivering care that actively values the client's differences and directly incorporates their preferences into the medical plan.
That makes a lot of sense.
The Association of Women's Health, Obstetric, and Neonatal Nurses, ACON, has a brilliant framework for this. They emphasize respectful maternity care built on mutual respect, shared decision-making, informed consent, and autonomy.
And this is incredibly critical for our LGBTQIA clients. These clients face severe compounded disparities.
Heavy disparities.
They are navigating heavy social stigma, much higher rates of depression in the perinatal period, and incredibly frustrating legal barriers. Sometimes they struggle just to get both parents' names on a birth certificate if their union isn't legally recognized in their specific jurisdiction.
It's exhausting for them. The priority nursing action here is to actively mitigate that stigma. You must use preferred names and pronouns. You must seek out cultural competency training to provide truly affirmative care.
But let me ask a highly practical question. If I'm a nurse and I've just explained a highly complex birth plan to a family whose cultural background and family structure are entirely different from my own, how do I actually verify that I've bridged that gap? How do I know they truly understand and agree?
You use the peach-back method. You ask the client to state back their understanding of the material or the care plan in their own words.
Just to make sure nothing was lost in translation.
Exactly. And crucially, this is a big one, never assume gender roles within the family unit.
What do you mean by that?
Do not look at a family and assume you know who the primary decision maker is based on your own cultural lens. You let the family define their own structure, and you respect it.
Okay, I want to zoom out for a second. To stop all of this, the structural disparities, the violence, the substance use, from escalating to the point of a terrifying emergency room admission, the healthcare system relies on tiered preventative care.
Yes, the levels of prevention.
And nursing instructors absolutely love testing you on this.
We do, because it proves you understand the timeline of a disease.
Let's turn this into a bit of a clinical scenario game to lock in these memory anchors. So what does this all mean? I want you to give me a clinical action, and I'll talk through which level of prevention it is so our listeners can follow the logic.
Let's do it. Scenario 1. You have a client who is 28 weeks pregnant, and you are administering the Tdap vaccine to protect the baby against whooping cough.
Okay, the baby doesn't have whooping cough yet. We are stopping the disease before it ever happens, so that is level 1. Primary prevention. Primary means to prevent. Another example would be running a teen smoking prevention program before they ever pick up a cigarette.
Spot on. Scenario 2. You have separated a pregnant client from her partner, and you are administering the HIT's screening tool behind closed doors.
Yeah.
Or you are sending a patient for a routine pap smear.
Right. We don't know if a problem exists yet, but we are looking for it. We are trying to catch it early. That is level 2. Secondary prevention. Secondary means to screen. early detection of a subclinical issue.
Exactly. Scenario 3. Your patient's infant has been diagnosed with severe neonatal abstinence syndrome. The ESC model wasn't enough, and you are now administering a careful dose of medication to manage their pain and seizures.
Okay, so the disease is already known, the diagnosis is confirmed. Now we are just trying to reduce the severity and heal the patient. So that is level 3, tertiary prevention. Tertiary means to treat. The same applies to giving chemotherapy to an oncology patient.
Perfect. And the final scenario. You have a client with a complex history, and a provider suggests an aggressive experimental intervention. You realize the side effects could severely harm the fetus, so you advocate against the procedure and protect the client from unnecessary medical intervention.
This is the ultimate embodiment of first do no harm. We are protecting the client from the medical system itself. That is level 4. Quaternary prevention. Quaternary means to protect.
You nailed it. If you can talk through those scenarios in your head, you will never miss a prevention question on an exam.
We have covered an incredible amount of critical ground today. Let's bring it all home.
If you only remember 5 things from this deep dive for your upcoming exams, make it these priority facts. Number 1, Black pregnant clients face a 3 to 4 times higher mortality risk, directly linked to the physical toll of social determinants of health and allostatic load.
Got it. Number 2, you must always screen for interpersonal violence in total privacy. Never with the partner in the room. Use the HITs tool.
Number 3, remember the mechanisms of substance use. Cocaine acts as a vasoconstrictor that shears the placenta off the wall, causing massive hemorrhage. Opioids act as a weight on the nervous system, leading to neonatal abstinence syndrome.
Number 4, the priority intervention for NAS is the Eat, Sleep, Console model. You rewire the infant's nervous system through low stimulation and bonding before ever reaching for pharmacological treatments.
And number 5, memorize your prevention timeline. Primary is to prevent, like a vaccine. Secondary is to screen, like a pap smear. Tertiary is to treat a known disease. And quaternary is to protect from medical harm.
Memorizing these facts isn't just about passing your NCLEX. It's about becoming the kind of safe, deeply aware, elite nurse who can actually look at a cracked social foundation and help change an entire family's trajectory.
Which leaves us with a final critical question for you to ponder as you step into your clinical practice. As modern medicine continues to push for highly standardized, rigid protocols to ensure physical safety and legal compliance, how will you, as a nurse, balance those strict binary hospital rules with the highly individualized, culturally dynamic, and beautifully messy reality of the human beings you will care for?
Keep that in mind the next time you look at a patient's chart. You're treating the whole person, not just the lab values. Until next time.